Little league shoulder. Now, I don't know how many of you, I think those of you who do have kids, they're a little too young to be in Little League yet. But when my kids were in Little League, when I lived in Santa Barbara, California, I remember a couple of times when the parents got into fights in the stands. And one parent actually was told they couldn't come to watch their kids play anymore because of it, and that they would actually call the police if he showed up. One issue with your patients when it comes to kind of teenage athletes, especially in this day and age where there's even more pressure on them, uh, is that the parents play a significant role. I'll talk, I think, some of anecdotes that we've had over the years, try to do studies in this population. But the parents definitely have to be involved in the decision making. The parents often have completely unrealistic aspirations for their children in this area, which can actually lead to frustrations and the diagnosis and treatment of some of these kids. But we'll talk about that. So uh, um, let me see. Um, let's see. Tayson's not here, right? Okay,
Yeah.
Robert, what do you think here?
All right, so we have some
This
X-ray.
is actually from this paper in this classic paper in American Journal of Sports Medicine.
Okay, so we have some X-rays of the shoulder, and looking at I believe it's a right shoulder, image A. Looks like there's some widening of the physis.
Right here,
Yeah.
here, a little bit of bony fragmentation there.
Hmm.
Normal on the opposite side.
Right.
So,
What else?
okay, what else?
Well, I guess, yeah, there's some
I
irregularity.
think it's slightly displaced, and of course you have a chip fracture there on the
Yeah. So,
metaphysis side.
so this is a classic growth plate injury. And in this area, this is really the hallmark on plain films of a little league shoulder, which is really overused and is really a Salter Harris, a low grade Salter Harris fracture of that proximal growth plate uh, here. And but of course, as we got interested in this with MR, I really feel that MR is a better tool for looking at this. What do you think here?
Okay, so 16-year-old pitcher with shoulder pain. Both of these images I'm seeing, I think, increased edema throughout the growth plate
Okay,
and maybe
some
some
edema of
widening.
the growth plate, maybe a little bit of the metaphysis here,
Yes.
and then here are other images. And sometimes this can be a little bit subtle. You want to pick this up before you have gross findings. But the clinical history and then this appearance of the irregularity of the growth plate here with a little bit of edema going into the epiphyseal region, that's really not normal. And this was another patient who had a little league shoulder. Okay, Pavan?
So we see some edema and widening at that lateral aspect of the physis, and then there's a little bit of edema in the epiphysis as well at that lateral aspect.
Okay. Okay, 14-year-old pitcher.
You want to give us a Salter?
Um, so it's, I guess it's probably a Salter 4, right? Because it's
What
through.
was it? So, okay, let's see. Well, what's a Salter one?
It's not displaced, so it's basically
So Salter
a
one.
one Salter one.
Yeah, Salter one.
Oh,
Good.
like slight.
Salter one is basically a fracture along the growth plate.
Okay.
And if it's picked up early and treated early, it has a very good prognosis. This is very active tissue and it can heal well. What's a Salter 2?
2 is when it comes from the like the metaphysis into the
Right.
growth plate.
Right. And a 3,
The 3 is when it goes from the epiphysis into the growth plate.
okay. And 4,
4 is all the way through, right? Or-
yeah, through both the epiphysis and the metaphysis.
Oh, right. Yeah. Okay. Yeah, I was thinking about
Right.
this. Yeah. So
And
yeah,
and they have progressively worse. And then what's a Salter-Harris 5?
it's like a crush injury.
Yeah, it's a crush injury, which has the worst prognosis. Good. Okay, so this is really a Salter-Harris 1 fracture involving the growth plate. You can see that this is chronic repetitive because you're getting a lot of erosive changes here. Normally, when we just see a Salter 1, the margins are smooth like we saw in the previous one. But if you continue to irritate it and not let it heal, you end up with these erosive changes on it, which is characteristic of Little League shoulder, where the player is pushed to continue to pitch by his coach, often by his parents, and by himself, even though to pitch through the pain. Fortunately, coaches now are getting more and more educated concerning these kind of injuries. But remember, most of these coaches are just kids' parents who have no formal training at all. So a lot of them still are macho and want the kids to play through the pain. And therefore, as a radiologist and the orthopedic surgeon, you really have to feel as though you're in a position where you've got to help protect the kids. And so a lot of these, if you don't know the referring physician, it's a pretty good idea to call them and explain the issues with them, and we'll see some of the complications if you don't treat these very early on. Olympus Vasti at Curlin Job and I tried to do a study where we were going to do bilateral shoulders and follow these over time. But with that particular study, prospectively, part of the protocol was that the patients would have to be taken out of throwing activities for a certain period of time, which is recommended by sports medicine people in that protocol. What he found is that a lot of the patients refused to let their kids get involved because they said that if they were going to take him out of pitching, they were going to change doctors. So even though the patients had significant injuries, so it can be frustrating to work with the kid, the parents, and the coaches when not everybody has the kid's best interest in heart.
And these are quite painful, so I don't think that, like for instance, a pitcher would not be able to pitch with a pain. Maybe in 2 to 3 weeks, it's a possibility, but not before that. So I think even the worst of parents can't make the kid do what he cannot do.
Well, so we've seen some of these go to displaced after months of pain while throwing. They actually ended up getting displaced fractures, John. So
I mean, the stress kind of fractures.
no, complete fractures with displacement of the growth plate.
Yeah, well,
I'll show some of those, I think. Here.
okay. They usually won't pitch.
Yeah. Well, yeah, I think this takes months to get this kind of change in the growth plate. Go ahead.
Right. So we have a 15-year-old with right shoulder pain and throwing pain for 2 months. Again, it looks like there's widening of the physis and a little fragment there and really erosive change of that distal metaphysis.
Yeah. So plain film, here's the MR scan.
So yeah, there's a lot of edema in the physis and kind of surrounding the physis as well.
Yeah. And maybe even a little slippage here.
Yeah.
Yeah, if this were in the hip, we'd call it slip femoral epiphysis.
These are not acute injuries, these are chronic.
Right, exactly. Because, well, this patient's been symptomatic for 2 months and
Yeah,
continued to play through this for 2 months,
that's
repetitively
a ball
injured.
of wax.
Yeah. Well, that's what we're talking about, the little league shoulder.
Yeah.
And then this is what we see is stretching physis.
but kids fall in the field, etc. So,
Okay.
but parents are terrible. In our school, where I was a team doctor for the football team mainly, um, the coaches only lasted 1 year.
Yeah.
I didn't get involved because I was not on the field except when my kids were playing.
Yeah. Right. Okay. So this is that same patient. Uh, Here we can see this is January 13th, 2012. This is March 28th, 2012. Supposedly he's resting between these in a sling. What did you think?
So it looks like there's narrowing of that physis now. Looks like there's almost sclerosis across that
Yeah.
physis there.
Yeah, so there's some bony healing here in this particular patient.
It looks like it's fusing.
Yeah, I think
And,
it's fusing.
how old is the kid by now?
Yeah, that's a good question. Let's go
It's
back and
15.
see. 15, so he's
So
probably
it's,
close to the end of
well,
his growth.
he's not going to grow much, so I don't think that's going to be
Yeah.
a big deal.
Yeah. So in the past, there were a lot of different terms for this that you might hear. Osteochondrosis of the proximal humeral epiphysis, stress fracture of the humeral epiphyseal plate, proximal humeral epiphyseal lysis, it's a common term I used to hear. Uh, and this is in adolescents with overhead throwing activity, and it's due to repetitive stresses. Well, there are other theories in the past, but I think it's pretty well proven now that it's chronic repetitive stress injury. And if you remember, these stress injuries at this stage are actually essential if you're going to be a professional pitcher because they lead to uh, changes in the morphology of the pitching side humeral head, which allows those individuals to get their arm in a much more cocked position, which gives them more arc to put momentum on the ball. And so a little bit is good, and a lot of injury or stresses are bad. And so the recommended treatment is take out of sports activities 3 months and use icing and analgesics. And this just shows some other examples of what to look for. It tends to be most prominently laterally, as we can see here.
Okay, 20-year-old baseball pitcher, shoulder pain. I'm looking at that growth plate. Doesn't look too remarkable. Not
Okay.
a lot of edema or widening.
And at this stage, the growth plate is really closed.
20, yeah. Yeah.
So actually, this is technically not little league shoulder because the patient is really too old for that at this point.
It's an adult.
Right. I'm not sure. Is there a little bit of edema there at some glenoid, maybe subchondral, maybe some edema
So
there.
there are other areas of the bone that you can injure by chronic repetitive trauma as well, and this is due to repetitive glenoid impaction.
Okay.
So it's another young person's injury, but this would not be called little league's shoulder. Okay.
13-year-old female baseball player with sharp pain on throwing, rule out labral tear. That inferior labrum looks kind of irregular. There's a little bit of like scalping or there.
This is probably the end of the labrum. Maybe there's a little irregularity of the inferior glenohumeral ligament here.
Let's see. Sharp. So there's some subchondral like cystic changes. And so it's probably some glenoid impaction injury.
Here you can see the irregularity of that subchondral bone. And this is again another glenoid injury from repetitive trauma. So this was a girl, 13-year-old, but remember that female physes close earlier, and so that this actually is a closed physeal plate, so it's not a little league injury. This is more like an older adolescent, young adult injury, which is impaction of the glenoid.
Was that underhand type of picture, or was that a picture, John?
I'm assuming it's underhand, but I don't know, John.
Yeah, okay.
Okay, so we have a 12-year-old motocross accident. Yes, looking at the again, superior glenoid, I think there's a little lucency there, maybe. Yeah.
A lot of irregularity down through here.
Yeah.
Something here.
Remember about this age group, um, the soft tissues are strong and firm. It's the bone that usually is injured.
Okay, so we see some glenoid irregularity on the plain films. Here's the MR scan.
Uh, Looks like there's a lot of edema along that lateral aspect of the physis. Yeah, and surrounding it.
And this is a month later. So this is ended up being called a Salter-Harris 2. We have a little fracture going through the metaphysis here.
Chip fracture.
No.
But these, the treatment for these are basically a sling for 4 or 5 weeks if you want to.
Good.
But no activity for a couple of months.
Yep.
In terms of sports.
Great. And here's someone who had a traction fracture, an avulsion fracture of the greater tuberosity. Okay.
Okay, fell off a ladder, persistent shoulder pain. The right PD fat side image, I'm seeing a lot of edema in that lateral humeral head. Yeah, with trauma, yeah. Yeah, a lot of edema. Could be an impaction injury. Maybe a little bone fragment there on the sagittal view on the left. That's just
Okay.
maybe
So this is
displaced.
10/23/19. Now we're going 3 months later, and this is what it looked like.
Right, so some scalloping of that humeral head, and looks like there's a bone fragment that's displaced by maybe the supraspinatus tendon.
Right.
Yeah.
That's more than one fracture.
Mm-hmm.
Yeah. And then a lot of tendinopathy and within the tendons, both the supraspinatus and infraspinatus.
Mm-hmm.
So this was probably an avulsion injury here that then they kept putting stress on it, and it didn't heal. In fact, it fractured, and then the bone displaced.
Mm.
Right. And here we've already seen this. This is well, actually, no, this is slightly a little different from what we've seen before. Go ahead, Pavan.
So it looks like it's a depending on how high up we are, it might be a posterior displacement
Okay.
or yeah, okay.
Yeah, so this is really a posterior dislocation and impaction, and here we can see that there is a fracture of the glenoid with an impacted a fragment here. So if this is left the way it is now, it'll heal in a position which would make the shoulder very unstable.
That's not acute, is it, John?
This is subacute at this point. There's still some bone edema here, but you're right. This isn't. This is probably a month or two old.
I agree with that. About maybe 2 months.
Yeah.
All right, so we have a couple axials here. Looking at the humerus, it looks like there's a lot of edema laterally, anterolaterally, and maybe a fracture there.
Yeah, fracture here. And then we've got to look and see try to figure out how many fragments there are. And to go through all the images, there are essentially 4 different bone fragments here. So this would be considered by the Neer classification a 4-part fracture. This involves both the anatomic and the surgical necks. And then there is a Neer classification here, which basically determines the number of different fragments. But the main thing is just the fragments, where they're located and how much displacement there is. If typically, even if there are a lot of fragments, if they're in pretty good anatomic alignment, they're typically treated non-surgically in this area. But if you have a lot of displacement, then you have to treat it surgically.
It's all about displacement. If it's no displacement, you treat it with a sling and a swath. If it's displaced, you have to operate on it.
Yep.
Okay, so here we see a fracture of the humeral head. I see two fragments.
Yeah, probably 1, 2, 3.
Oh, okay.
And then there's a lot of displacement here. There's rotation, and it's involving the humeral articular surface
Mm-hmm.
here. So, John, how would you treat this?
Operatively.
Yeah.
Surgically.
Yeah. Okay, come on.
86-year-old male, status post-fall, fracture dislocation. So we're asked to evaluate the status of the tendons. And
This one I would treat with prosthesis.
it looks like the humeral head's actually inferior to the glenoid.
Yeah. So multiple fragments, and then we look at.
I would imagine there's a nerve injury here.
Yeah. So can't really make out much, honestly.
So it turns out you need the whole study to evaluate this, but if you then need to follow the tendons, and it turned out each of these tendons went to a different displaced fragment in this particular case. But yeah, this is a very tough case.
These are usually you use a single prosthesis and cement.
Okay,
And they do pretty well.
great.
All right, so we have some images of the shoulder, and it looks like there's a fracture of the glenoid superiorly.
Yeah, this is a kind of a young patient.
Okay,
This is that growth plate hasn't really fused yet,
I see.
but this is not normal here.
Mm-hmm.
And that's a forefoot base fracture.
Okay, so
That's
here.
conjoint tendons attached in that vicinity. I wonder if it's a pulled fracture. You don't see too much edema there, John, do you?
No, not too much at this point, right?
Hmm. All right, so fracture of the proximal humerus and the humeral neck.
And the cervical spine.
Yeah, you could certainly see a
Okay.
lot of atrophy of the muscles. This is probably primarily the surgical neck, and we can see that there's a lot of hypertrophic bone here. So this is really a chronic non-union in this patient. And John might be
The
right.
only thing to do here would be to do a fusion if there's a lot of pain. Or a hanging hip where you remove the head and just leave the humerus where it is.
Okay.
There's an 80-year-old female, limited range of motion for a month in pain. Hmm. There might be a little bit of supraspinatus tendinosis and at that insertion.
Okay.
There's like some edema, so possibly partial tear.
Yeah. Remember, we're talking about fractures.
I think that, okay, so I don't think it's just a slice. I think there's a femoral neck fracture, like right there. Or sorry, humeral neck.
Humeral neck?
Yeah, or like
Well, I think we're getting out of it
proximal
here.
humerus.
What about here?
Mm.
I'll
So,
show you another image.
Scapulus fracture also.
okay, so scapular, maybe like the spine.
Yeah, this was a scapular non-union. And the reason I really want to bring this up is uh, they're not very common, but they're commonly missed. And it's just that your usual uh, uh, way you scan images, people don't spend a lot of time and effort to the scapula here proximally. Most of the business we look at is over here. But just remember that for chronic pain syndromes, you can have scapular fractures, and they're uncommon, but they're not rare.
All right, so we have a couple coronals of the shoulder. I don't see any obvious fracture. There's some linear. Yeah, I don't know what that is exactly. I don't want to see some other planes.
Yeah, this is basically the glenoid. Here's the scapula, and there's the scapula.
I see.
So this is a displaced scapular fracture.
Got it.
Again, they can, in retrospect, it's kind of obvious that this should be over here,
Yeah.
but it's very easy to overlook this. So
Mhm.
just kind of put it in your mind.
It's the T2 that saves you.
Yeah, that's right.
Okay, so once again here, medial to the glenoid, there's irregularity of the scapula.
Ah, you guys are picking up on this.
Yeah.
Yeah, so repetition sometimes is helpful, but it can be difficult if you're just looking through a big stack of films
Mhm.
and you're looking at rotator cuff tears. Okay.
Okay. So it looks like we have quite a bit of edema in the humeral head. It might be centered at the lateral aspect.
Okay, so this is 10-5-10. Here's some more images, images.
Okay.
Oops. 10-5-10, 10-5-10.
Okay.
So this patient had trauma. We can also see there's a little kind of osteophyte here, but this looks to me like probably a fracture.
Yeah.
Might be concerned, well, maybe it could be a pathologic fracture. I don't think it was in this particular case, but there could be a mass coming out here. So
Yeah, there's a little thickening
consider
there.
about that. Patient had trauma. Okay, now the patient comes back 3 months or 4 months later, and this is what it looks like.
So I would say I mean, there's like areas of sclerosis, but there's it's non-healed. It's like a non-union
You
essentially.
see a lot of stuff here.
Yeah.
I mean, you got this kind of funny thing there. If we go back here, that looks normal there.
Right.
But now, and you got a little,
It's like
almost
a
a double line
divot.
sign there. It's very irregular, margin, a little bit like a snake.
Mm,
And this is a post-traumatic AVN
okay.
because that segment of bone lost its vascular supply.
So we have history of treatment for breast cancer, fracture 1 year ago, 3 months of increasing pain, and there's that I guess serpentine increased signal on the PD FANSET images. So again, I'd be concerned for an AVN.
Yeah. So yeah, another AVN, post-traumatic AVN.
Right. So again, here, humeral head, middle PD FATSAT image, we see kind of the double line sign concerning for AVN.
Yeah, so this is another osteonecrosis with secondary kind of impaction injury and degenerative disease. Okay. Fine, you're getting the good cases.
So professional diver. And it
Abalone diver.
looks like it's mostly it's kind of on this in the subchondral region, and then you have a little bit of involvement right there. Um, so if he's a diver, he could have this might be pushing it, but that it might be a bit of a stretch, but if he's a diver, he could have the like if you come up too fast, you get emboli. Yeah.
Yeah, called Caisson's disease. That's
Okay.
what he had.
Okay.
He wasn't careful enough.
I think we have 2 or 3 oxygen decompression facilities in Southern California.
Yeah, another name for this is dysbaric osteonecrosis.
So we have a 35 year
The sooner you put them in a decompression chamber, the less chance of this happening.
Right.
Okay, so we have a 35-year-old with ulcerative colitis and shoulder pain, and there's a lot of irregular signal in that humeral head. Yeah, again, kind of throughout. So
kind of this kind of a regular serpentine type pattern. And this turned out to be a vascular necrosis.
Okay, shoulder pain, relap mass. This radiograph, maybe in the greater tuberosity, there's some lucency there.
Now,
Yeah.
the patient came back on 11/2/05.
Okay, so that lucency is now kind of just irregular. It's kind of a mixed signal, yeah.
You see what the MRI scan is like.
Okay, so yeah, maybe an avulsion injury.
Right.
Yeah.
And then if you go back here, actually, there's a normal lucency here. I remember many years ago, there's a famous musculoskeletal radiologist by the name of Murray Delinka, and he was shown a case like this as an unknown at the RSNA. And there's a big debate over this. That particular case, they ended up saying was normal. But in this particular case, that's we see that it actually progressed here. But this is often a lucid area.
The fact that there's pain, that makes it, well, you know more about it than I do, John, but that makes that lucency a little more important because of the pain and probably tenderness too.
Yep. Okay, let's go on and talk a little about acromioclavicular joint disease. And I think you're all familiar with the Rockwood classification. Basically, you have normal where the acromioclavicular joint and corticoclavicular ligaments are nicely intact. Type 1 is where you have a sprain of the acromioclavicular joint capsular ligaments. and the corticoclavicular ligaments are intact. Type 2, you have a rupture of the AC ligaments and a spraying of the corticoclavicular ligaments. Type 3, you have ruptures of both, but without a lot of displacement. Type 4, you have a type 3 where you have ruptures of both, but you have a posterior displacement of the clavicle. At type 5, you have a type 3, but you have separation, often injury to the fascia superior to the AC joint. And typically the acromion process, the superior margin of the acromion process is inferiorly placed with respect to the inferior margin of the distal clavicle. And then at type 6, you have an inferior clavicular dislocation, which is typically, a lot of these patients don't survive. This is more of a motorcycle type accident with high power. Too bad that this is, I think, the progression where you saw these. Type 4 really should be, type 5 really should be type 4 and type 4, type 5 in terms of progression of severity of the disease. The cutoff point is generally considered a type 3 between surgery and non-surgical. Types 1 and 2 are non-surgical. Type 3 may or may not be surgical, though in this day and age, most of the people I know will rarely operate on type 3s. And then type 5, 6, and 7 are generally considered operative lesions. So here we have normal. You have the corticoclavicular ligaments here, the coronoid, and the acromioclavicular joint with the capsular ligaments there. So here you can see the corticoclavicular ligaments well in primarily the coronal and sagittal plane. I like to always look at it in the sagittal plane where you can see it goes between the coracoid process and the clavicle here. And then here we can see the acromion over there. So we're medial to the acromioclavicular joint. Here we can see a situation where we have a lot of edema around the acromioclavicular joint space in this location. The corticoclavicular ligaments were intact. So this would be a type 1, a Rockwood type 1 injury. Okay. Let's see. Pavan, what do you think of this case?
It doesn't look displaced, but there's some edema, so maybe like an AC strain, and so type 1.
So you can see a tear here with some fluid extending outside the capsule superiorly. So what's the next thing you want? Well, here's an axial image that actually shows that you've got some injury here to the distal clavicle as well. But what are you concerned about at this point? What would you like to see?
Probably a sagittal.
Looking for what?
The coracoacromial ligament.
Corticoclavicular.
Yeah.
Okay, there it is.
I would say it's at least partially torn.
Well, yeah, it could be. There's a little bit of signal here, but you can see here is the attachment, and there are two components we'll talk about in a minute, I think. Here you can see this attachment looks pretty good to the clavicle, and then here it looks like a little bit odd coming down to the coracoid process, but if we go to the next cut, the coracoid insertion looks pretty good. So I think this is just a small kind of attenuated corticoclavicular ligament, but it's intact. On the coronal images, we can see the corticoclavicular ligament here, and a little bit of edema here, but this is generally thought to be a type 1 football injury.
You can make that diagnosis with weights and take
Holding
X-rays of both shoulders.
Yeah, AP X-rays.
5 pounds in each hand.
Yeah. This just shows, this is actually, we did an MR scan on a bunch of MR scans on a bunch of athletes at the Maui Ironman competition back in, I think it was like 2005 or 2006. and we published it in Skeletal Radiology. What we found, and we took clinical histories and did an MR scan, what we actually found is it was very common to get edema around the acromioclavicular joint and these Ironman athletes who are completely asymptomatic. So the edema in the bone, most places, is a pretty good indication that correlates with symptoms, but we found that not to be the case with the AC joint, and many of you have seen MR scans where you see degenerative disease of the AC joint with some edema adjacent to it. We don't have very good clinical histories in our patients most of the time, but we pass it off as degenerative disease, and most of these are not symptomatic.
It says Ironman athlete with pain.
Oh, yeah. This guy had pain, but in our studies, we found that a large number without pain had similar findings. And that
What I would do is,
correlate very
if I was checking these people out, I would put pressure on that area if I get tenderness.
yeah,
Because these people have so much adrenaline flowing in their
yeah,
system, and morphine kind of effect, that they don't feel pain.
yeah.
But you can press on them and they'll get tenderness.
Okay.
Was this edema before or after the race?
We actually imaged them both ways, before and after. And I don't think it rarely changed.
I think it's
Go on.
no,
Oh, just
yeah, he just did one. 36-year-old weightlifter with shoulder pain. So yeah, there's edema in the AC joint with irregularity on the clavicular side.
yeah, really on both sides. We don't really see good subchondral bone here. And by the way, when you're born, you have cartilage here. You have a diathromidal joint. In most patients, by the age of about 20, the cartilage is no longer completely intact. And you see, we rarely ever in adults will have an MR scan where the AC joint's normal. And generally, by the mid-20s, most people, the articular cartilage has been eroded away. So this in the past was called osteolysis. And I guess people can still use that term, but that's kind of a term that was used a lot with plain films. And then here we can see the irregularity and little subchondral cystic changes, erosive changes here in this. And this is just repetitive trauma producing osteolysis and degenerative disease.
So this is not nothing on the other side, John?
I don't have imaging of the other side. Most of the time, in these kind of patients, this is going to be symmetric. It's going to be on both sides.
Yeah, I would think so.
Yeah, unless they're a picture or something like that where they have unilateral involvement. And this was a study in skeletal radiology where they looked at this and they found that the heavier the weights, the more likely you're going to get these changes to the acromioclavicular joint. Okay, let's move on to type 2. And type 2, you've got rupture of the AC joint capsule and ligaments and strain of the CC ligaments. So here we can see kind of a tear of the AC capsule, and here we see edema within the corticoclavicular ligament. And here's another patient where we can see a rupture of that superior capsule of the AC joint. And if we go on the coronal plane to the CC ligaments, we can see edema here. These are both type 2. And here we can see some separation and obviously a rotator cuff tear. Okay, Ivan, you next? All right. Okay.
So now we have a 13-year-old male with a sports injury. And surrounding that AC joint, looks like there's a lot of edema fluid.
You're right, distal clavicle. Yep.
Uh, Here, there's looks like there's a tear of the corticoclavicular ligaments.
Well, there's edema in it.
Mhm.
It looks to me like there's still fibers intact. So I think this is a type 2,
Type 2.
where you have a rupture of the AC capsule and you have a strain, but not a complete tear of the CC ligaments. And then we can move to type 3, where you have tears of both of those.
Okay, so here, yeah, there's widening of the AC joint on the right image. Yeah, it doesn't see
Yeah,
much
so
else.
type 3, if I saw this, I would be concerned about a possible type 5.
Okay.
You have to skip past 4. So what's the next thing you want to look at?
At the corticoclavicular ligaments. Yes, and those look torn.
Both the coronoid and the trapezial components of it are torn through here.
Mhm.
The sagittal images, you can see the tear there.
Yes.
So there wasn't a lot of displacement on physical examination, so this was thought to be a type 3. And the vast majority of these that I've seen in recent years have been treated conservatively. Okay.
It depends on what the patient wants, John.
Yeah.
Especially women, they don't like a big bump pushing up there in the shoulder.
Okay.
Doesn't look very good, so they rather have a small scar. It's
Okay.
not that difficult to fix, so
Okay.
you get a very small scar, at least the way I did the surgery.
Okay.
So they can be very persistent and go doctor shopping, so
Okay.
they'll find somebody to do the surgery.
Thanks, John.
So some edema of the acromioclavicular joint and then disruption of the ligament.
Okay, so now what do you want to look at next?
I would like to look at the corticoclavicular ligament, which,
This is the coronal plane.
oh yeah, there's a transversely oriented tear through it, so separated.
This would be another type 3 or the sagittal images.
Yeah, so we see another tear.
That's really good. The other thing that you can occasionally get is an AC joint tear and displacement and a fracture of the coronoid process rather than a tear of the CC ligaments too.
I mean, the coracoid process?
Yeah, I mean the coracoid process, right?
Yeah.
Thank you.
Yeah, usually in kids.
Yeah.
So we have an 18-year-old with shoulder pain after trauma. Again, there's a lot of edema surrounding that AC joint of the tear of the capsule.
Okay.
And it looks like there's complete tears of both corticoclavicular ligaments.
What's that little thing right there?
That looks like an avulsion fracture.
Yeah. And here are the sagittal images.
Yeah.
And remember, 18-year-olds are still immature when it comes to bone maturity.
Okay. So this is actually a displaced fracture, an avulsion fracture from the coracoid process. And then there's a type 4, which is a type 3 with a posterior displacement of the clavicle. So in this case, the clavicle is displaced posterior to the acromion after all three of the coronoid, trapezoid, and the AC joint capsule are torn.
These have to be reduced and fixed surgically.
Okay, 28-year-old male, 2 weeks after MVA. Yeah, we see widening of the AC joint. Lots of edema there. And on the axial on the left.
And here's one image. So in this image, this is the top of the glenoid,
Mm.
and that's the coracoid process there. Now let's do one image above that, and this is what we see.
Okay. Okay, so the clavicle looks like it's displaced posteriorly a little
Right.
bit.
So there's the superior glenoid, so the clavicle is posteriorly displaced.
Mm.
That's what makes this a type 4. And here, if we follow it, the clavicle is way back here, the AC joint should be up here. So this is where you have a CC ligament tears, capsular tears, and then you have a posterior displacement of the distal end of the clavicle. So that's a type 4. Yvonne, here's a snowboard injury.
Having some difficulty making out. So I think that's the on the two images at the top. Is that the clavicle that's kind of posteriorly?
Yeah.
Yeah. Okay. And then we.
Here, so it's actually coming posteriorly, right?
Yeah.
The fat says here you can see on the sagittal images the distal clavicle is posteriorly positioned.
Yeah.
And so this is another Lockwood type 4. And then Rockwood type 5 is where you have a separation of the AC joint with significant displacement. And these generally are considered to be operative type lesions as well, though there's a few of these.
Yeah, they cannot be reduced. They perforate the trapezius.
Yeah. And so here you can see it. And often with these, what you'll get is an injury to the trapezial muscle up here in the capsule. And typically, I kind of use the cutoff where if the superior cortex of the acromion is below the level of the inferior cortex of the clavicle, then I consider it most likely a type 5.
And it would be a lot higher, but the fact that the trapezius is perforated, it won't go any higher.
Yeah. And this is the symptomatic side, the asymptomatic side from France. And there you can see the inferior displacement of the acromion process. And here's the MR examination showing the injuries to the CC ligament and the capsule. And this was a Rockwood type 5. And here, as you can see, the area where you have the fascial tear. And here's another Rockwood type 5 CC tear, AC joint with inferior displacement. And this just kind of shows the different kinds. Why don't we stop here, and when I get back, we will talk about surgeries for these. Okay?
Where are you going, John?
Just 1 second here, John. I'm going to London for the International Skeletal Society meeting.
When are you coming back?
I'm leaving tomorrow, and I'll come back a week later on Saturday, so I'll be gone all next week.
Okay, so I'll see you a week from Monday then.
Exactly. Good. Thank you.
Make sure you take a plane without the parts being faulty.
Wait, take a plane without the parts being what?
The engines, the GE and some other, I think it's only GE, have had some fake parts put in them in the engine.
You're kidding me. That's terrible.
No, I'm not.
Wow.
I don't know how many planes that they have the problem with, but they have to be replaced.
Where'd they get him from? China?
Probably from China.
Oh my God, that's terrible. Okay, John, thanks. I'll
Yeah.
ask when I get to the airport.
Yeah, make sure that that plane has been checked properly.
Yeah. Thanks.
Have fun.
Yep.